And we're live.
Okay. Well, good morning, everyone, and welcome to our last commission meeting of the calendar year. I'm Valerie Sullivan, Chair of the GIC, and I want to welcome everybody who's watching via YouTube and want to wish everybody a very happy holiday season. I am joined with my esteemed colleagues on the board, as well as the GIC staff. So I'm going to turn it over to our General Counsel, Andrew, to announce our other commissioners and start this meeting. So good morning, Andrew.
Good morning, Madam Chair. In addition to our Chair Sullivan, our Vice Chair Kaplan, a designee from Department of Insurance, Rebecca Butler, Commissioner Choate, Commissioner Davis, Commissioner Edmonds, Commissioner Gentile, Commissioner McEnany, Commissioner Murphy Rodriguez, Commissioner Silva, Commissioner Sinenko, Commissioner Tim Sullivan, and Commissioner West have all joined us this morning, and there may be a few others that will be joining us subsequently.
All right. Well, thank you very much. So at this point, I'd like to turn it over to Matt, who will go over the agenda and give us a view of what we'll be discussing today.
Terrific. Thank you, Madam Chair, members of the Commission. It's a delight to see you on this beautiful day outside the window in my 14th floor office in Ashburton. It's a beautiful, crisp morning. So great to see you all. So we have three main substantive items on our agenda today, which may look like a light agenda, but I can assure you it's not. In addition to our director's report, we will start with our dental and vision procurement recommendation, which our team has been very hard at work on for several months, and we'll be bringing you their recommendations. I want to acknowledge at the outset Janine Dewar, our manager of pharmacy and ancillary benefits, who led that procurement, and the rest of the procurement team for that. So for that, we'll be handing it to Jim to introduce Janine, who will walk through that deck. Second item is to provide you our FY 2026 preliminary cost increase. So this, of course, is the beginning of the process that we will talk a little bit more about in a moment when we look at calendar. And then we will conclude with our CFO report from Jim Rust. We now have 5 months worth of claims data on this fiscal year, and we want to bring you up to speed with how we are doing, what that looks like compared to budget. So that's the agenda for today.
Thanks, Matt. It's a busy agenda for sure. Always that time of year that we might not like when it comes to talking about preliminary premiums. But before we get to that, let's talk about last meeting and get a motion to approve the minutes from our September meeting.
So moved.
So that was Eileen.
Second.
I think that was Toby. So all in favor of approving the minutes from our November meeting. Sorry, I'm a little bit behind on that. I say I'll entertain an aye, nay, or abstain. And I'm an aye. I'm going to ask Andrew to take the vote. So thank you.
We just need someone to make the motion, Madam Chair, other than the chair.
It's been made.
I thought
Commissioner
Eileen.
McEnany made it.
Oh, okay, sorry.
It was
My
seconded
mistake.
by Commissioner Choate.
Yeah.
Vice Chair Kaplan?
She must be on mute.
Yeah. Designee Sullivan. Go ahead, Vice Chair.
Aye.
Thank you. Designee Sullivan?
Abstain.
Designee Butler?
Aye.
Commissioner Choate?
Yes.
Commissioner Davis?
Aye.
Commissioner Edmonds?
Aye.
Commissioner Gentile?
Yes.
Commissioner McEnany?
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
thank you, Commissioner Sullivan,
Yes.
and Commissioner West.
Yes.
The vote passes unanimously of those voting.
All right. Thanks, Andrew. So at this point, let me turn it over to Matt and we'll dig into the meaty agenda. So thanks.
Thank you, Madam Chair. So we'll move first to Executive Director's Report. We have provided you all, as we always do, with a written report prior to the meeting. In the interest of time and given today's weighty agenda, rather than walking through each item, I'm happy to entertain any questions commissioners may have. We'll just note we have some job openings listed there. And I do want to note that Leslie Montero, our Director of Communications, had the pleasure of welcoming a baby boy, Michael, into their family. So we won't have her services today, but she's doing very important work with her family. With that, happy to take questions.
I don't see any hands up, so we can keep moving, Matt, but thank you and congrats for sure to Leslie.
Thank you, Madam Chair. We'll move on to calendar review. Just making sure I have my notes. Okay. So commissioners, here we provide you with dates for the meetings for the rest of the fiscal year. Today's meeting, of course, as I mentioned, kicks off the process of making rate decisions and plan design decisions for fiscal year 26. Today, we present you, as we always do, with our preliminary aggregate average cost increase across our plans. This has been, as it always is, a detailed and lengthy process of us doing a great deal of due diligence to understand what the cost will be for the coming year. So we will hear from Vince Kane and the Willis team, in addition to our dental procurement. In January, we come back and present you with proposed plan design changes and provide you an update from our recent stewardship meetings with each of our carriers. Then on the 28th of January and the 30th of January, we will hold our public information sessions. As a reminder, this is where we present the proposed preliminary cost increase and any plan design changes to our members. And then we come back to you in early February. I will note we have 2 meetings in February this year. And this is to ensure that we have enough time to do the work of preparing rates ahead of annual enrollment. So that first meeting in February, we will present our recommended plan design changes, and that will be for a vote. And then on the 27th, we will return for the final stage of the commission process here, which is to bring you final rates that wrap up all that work, and we'll bring those to you for a vote. Just a reminder that we present this to you all in this order because any plan design changes that may impact final rates, the commission must vote on before we can actually calculate those rates. So it's a stepwise process, and today begins that process. I also just want to note that as I did in the last meeting, our plan is to fold in over the coming meetings further discussions on items that we briefed you on in September. These are the priority areas of the GIC regarding health equity and behavioral health. There's a great deal of work happening in both spaces as we speak. So as that work continues, we will be back for more details and discussion with the commission. Happy to take any questions on the calendar.
Well, I, for one, want to applaud the focus on health equity. So definitely looking forward to hearing and staying close to what's going on there. I see Bobby has her hand up, so go ahead, Bobby. What question?
It's about the calendar, sort of, but my dog was barking, so I couldn't ask the question previously regarding the informational sessions that are going to be held in January. So this seems to be fewer sessions than in prior years. And I was wondering what the reason was, and if there could be one of those maybe, rescheduled for like lunchtime, because that's probably the best time, like the 12 o'clock, if you could add on another, or like I was curious what the reason is to only hold 3.
I think I will turn that to either Emily or Erica to answer that. I think probably Emily.
I'm happy to take that, Matt.
Thanks, Erica.
We actually have the same number of sessions that we've had for the last 4 years. So we've always had 3 sessions, and we try to scatter those sessions around in terms of the timing, so that we can offer different times for people as it works for them. So we have a morning session, a lunchtime session, and an evening session to accommodate all sorts of schedules. Those meetings will be recorded as they have been in years past, and placed up on our YouTube page, along with us kind of collecting FAQs from those meetings, and posting them onto our page website as we get new questions for the year. Those FAQs are also available year round. So same amount of sessions as we've had, all will be recorded. And I will be sending around a Zoom link for those if commissioners would like to attend.
Thank you. Erica, do you know if like how many hits you get on the recorded sessions? In other words, after, let's say, the informational sessions are held live, like how many people sort of take advantage of the recorded?
Yeah, I'd have to go in and to our YouTube page and just double check on that data. Usually that's something that our esteemed director of communications would have a handle on. So I will find that information for you, and I can certainly get back to you with it.
All right, thanks.
Sure.
Thank you.
Yeah, and thank you, Erica. My recollection from last year, Bobby, it's not perfect or exact, but that we more than tripled the number of people who attended sessions remotely, either on the live YouTube or recorded, than we ever did with the in-person. So I'm excited about our reach over the last 4 years, even though we've had fewer sessions. I think the data will say that we've touched more stakeholders, and I know qualitatively that's the case. I don't know quantitatively. And so it sounds like that's an action item Erica and the staff will take back and bring to us at the next meeting. But I know their commitment, our commitment is to making sure that our constituents are able to be heard and have a voice in what we do. And so I think the staff has done an excellent job of that. All right.
And I agree. Yeah, I agree.
you.
I think they're terrific, the informational sessions.
All right, let's keep moving because we
Thanks.
have a very busy agenda. So thanks, Matt and Erica. And I know the notes will reflect that we're going to circle back on that.
I see we have Commissioner Edmonds with a question.
Well, since we're going to be taking a look at the data, my question kind of builds on Bobby's, in as much as I'm wondering, in terms of the reach, that's great that we're touching more people, but I'd be curious about the demographics associated with that reach. In other words, is there any information that gives us a sense about who's more likely to pay attention to the recordings and who might still not be touched?
Thanks, Commissioner. I don't know that the data that our YouTube page provides would get to that level of demographic, but I can certainly look and see if that's something that that they do provide, perhaps by geographic region. That might be something that they provide. So let me look into that and see what data that they do offer, and I'd be happy to come back with that.
Thank you very much.
Sure.
All right, great. Thanks. Good question, Jane.
Thank you.
Before we move to the, I'm sorry, if there's any more questions, happy to take them. I don't see any. Before we move to the next agenda item, I just want to make one quick housekeeping note that we do have follow-ups from our November meeting, and I think we may have an outstanding follow-up or two from our prior meeting. We have not lost track of those, and we will circle back with you on the items that we have on our list. So just want to assure you that we haven't lost track of those.
Thank you, Matt. That was directed at me. I appreciate it.
Oh, not just you, Madam Chair. You're not the only one.
All right, great. Let's keep moving.
So here I turn it over to Jim to introduce Janine.
Morning, everyone. I'll just briefly introduce Janine here and remind everyone that we procure for all our vendors every 5 years or sooner, but we must do it every 5 years. And that's what brings us along now to have a recommendation for you for a dental vendor, dental and vision vendors. So I'll hand it over to Janine, who will go over the process and the team and the scoring that went into this. Janine?
Thank you, Jim. I'm Janine Dewar, and I'm the strategic sourcing team leader for this procurement. As Jim said, can you advance to the next slide, please? Thank you. The GIC is currently in its 5th and final year of contracts with MetLife and Davis Vision for dental and vision services, respectively. In anticipation of the end date for these contracts, the GIC partnered with our consultants at Lockton for this procurement for services beginning in FY26. On this slide, we've included a high-level procurement timeline leading up to the presentation of our recommendation today. Next slide, please. The GIC received 3 bids for dental and 2 for vision. For dental, we received bids from MetLife, Altus, and Point32 Health. For vision, we received bids from Davis Vision, which is a subsidiary of MetLife, and Altus, which partners with VSP for its vision plan. The GIC and Lockton scored technical and cost proposals, and the GIC evaluated supplier diversity commitments. Based on initial scores, MetLife and Altus were selected for oral presentations for both dental and vision. Finalist interview scores were incorporated into each bidder's total score. Finally, we requested best and final offers, giving bidders an opportunity to clarify or revise any components of their bids. And bidders are not required to make changes, but in this case, cost proposals were revised and cost scores were updated accordingly. Next slide, please. Based on our evaluation of all phases of the scoring process, the GIC's strategic sourcing team recommends awarding both the dental and vision contracts to Altus. Under Altus, active and retired employees will pay less dental premiums, and the savings over the span of the contract could allow us to explore opportunities to enhance plan benefits, increasing the value of the benefit at a minimum impact to the state and the members. The premiums for years 1 through 3 will be shown on the next slide. We're confident that the switch to Altus will have, you can go back, thank you. We're confident that the switch to Altus will have minimal disruption for our members, as Altus offers a comprehensive provider network, and they have committed to adding additional in-network providers in the first year. Altus also has experience working with the GIC in this capacity, as they were the dental vendor when the retiree dental plan was first introduced. For vision, the proposed administrative fees result in substantial cost savings for the GIC, and active employees and their dependents will maintain the same level of benefits, similar access to providers. While the retiree discount plan will offer slightly reduced discounts, we believe that the switch to Altus will be a net positive. Retirees will no longer have to prepay to receive discounted services, and we believe that this will be helpful in increasing utilization. So overall, Altus's bid is financially advantageous, and savings combined with dedication to account management, commitment to network growth, and member experience were key factors in our decision to recommend Altus as the apparent successful bidder for dental and vision services. Next slide, please.
Sorry, I saw that Bobby had a hand. If we can just pause there for a moment on the prior slide.
Thanks. I was curious as to the networks, the difference in, provider networks and what that looks like. Maybe my question's a little premature and I should wait a little bit. But I was curious how Altus's network compares to MetLife as far as the providers, particularly in the western part of the state and maybe in, more rural areas.
It's a good question. The networks are comparable. We did have each bidder provide information on geo-access information, and based on the information they provided, we believe that members should not have any issue accessing a provider close to their home. And like I said, they're comparable in size and accessibility.
Because we, often receive questions regarding, the providers who, some didn't even accept MetLife. So I'm curious what that might look like.
Just based on our discussions with the bidders and the information that they provided, we don't anticipate disruption. We believe that members will have access to providers that are close to their home, and that will take Altus dental insurance. So
I will say, whenever you develop a network-based plan, whether it's on the health insurance or dental side, it's not likely to include every dentist, and it may mean that a dentist that a member sees today is not included in the network. It's part of our evaluation of all the sort of pluses and minuses here. I think what Janine is saying, that we have a pretty high level of confidence that that each member will have, convenient access to providers that are within their geographic area.
Thanks, Matt. I also want to add that there is an extensive out-of-network benefits. So members shouldn't have an issue with that either, and the rates for out-of-network.
Thank you. And it's a 3-year contract, right, with 2 1-year extensions.
That's right.
Right. Okay. Thanks.
You can keep going, Janine. You're doing great.
Thank you. So this slide shows the breakdown of the current dental premiums and the premiums under Altus for the first 3 years of the contract. So it's important to note here that these are not the same as the premiums that members will pay. Members pay a combined premium for dental and vision, and the vision rates shown here are only the administrative fees. Also, active members only pay 15% of the total premium. And so with that, I'm happy to take any additional questions.
Bobby, did you get all your questions answered?
Yep, so far. Thank you.
So I don't see any other questions, Janine. I think you've been very comprehensive in your overview.
Thank you.
So at this point, I don't see any questions. So I'd like to ask for a motion to approve the GIC contracting with Altus as the apparent successful bidder for dental and vision. And this has been recommended by the procurement team. So do I have a motion?
Motion to approve.
Toby, second?
Second.
Okay, that's Catherine. So at this point, let's take a vote. Andrew, I'm going to go with aye. Go ahead and poll our team, please.
Thank you. Vice Chair Kaplan,
Aye.
Designee Sullivan,
Aye.
Designee Butler,
Aye.
Commissioner Choate,
Yes.
thank you. Commissioner Davis, I'll skip down to Commissioner Edmonds, who's on the ferry.
Aye.
Thank you. Commissioner Gentile,
Yes.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Silva,
Yes.
Commissioner Sinenko.
Aye.
Thank you. Commissioner Sullivan,
Yes.
Commissioner West,
Yes.
and Commissioner Davis, if you're available. All right. The motion passes unanimously of those voting.
All right. Well, thank you very much, everyone. Good luck negotiating a
Thank you.
terrific contract for us with Altus. Make sure that network is as solid as they say it is, especially in the western part of the state. So with that, we'll move on. We'll have our friends from WTW are presenting. So they're up next. So I'm excited to hear what they have to say. So Matt, do you want to introduce this topic, or do you want me to just pass it on to WTW?
Sorry, I was doing so under mute. Forgive me. So this commission will recognize our two presenters here today, Vince Kane, who's the Senior Director of Health Benefits at WTW, and Dr. Jeff Levenshires, the Population Health Lead at WTW. They're here to present on our FY 2026 preliminary cost increase. They continue to be extremely valuable assets to our team as we prepare and try to look forward actually into what healthcare costs are going to look like starting next July, which is never an easy thing. I would say this year it has been especially challenging because there are a number of emerging dynamics, escalating dynamics, ones that we're very well aware of, but just a very uncertain environment as well. So it's been particularly challenging this year. So with that, happy to turn it over to Vince and Jeff to walk us through what that exercise has produced to date.
All right, thanks, Matt, and good morning, Madam Chair, commissioners, and members of the GIC staff. So this year, we've got some additional detail given the increase that we're looking at on a preliminary basis. And so we're going to be doing a broader sort of market update to set the stage for some of the drivers that are affecting healthcare costs and pharmacy costs in 2024, but expected to go forward into next year and the year beyond. So, why we're here? Well, we're giving the first view of the FY 26 full cost premium rates for the non-Medicare plans and the Medicare plans for GIC for FY 26. So this is work that I lead as the actuary and head of our financial team at WTW in developing our projections. But it is a collaboration not only between WTW, but also the carriers, so the medical plans that the members are enrolled in, as well as the PBM, CVS Health. So, what we do in developing our projections is collect claims, membership, risk information from FY 24, and then use a range of assumptions to project that out to FY 26. The full cost premiums reflect both the state share, the Commonwealth share, as well as the contributions that the member pays. It does not include the out-of-pocket costs. So, for example, office visit copays, deductibles, pharmacy copays, etc. Now, virtually all of the plans offered to GIC non-Medicare members and Medicare retirees are self-funded. So, what we're doing is looking at the claims that the state is paying, and then, basing our projections off of the membership that incurred the claims and trend assumptions that are provided by the carriers. So we reach out to the health plans and we ask, what is the prospective trend estimate to account for utilization and unit costs to move us from last year to FY26, where we're making sure that we're covering the expected utilization of claims, but also admin fees, etc. There's one exception, and that's for the Medicare Advantage plan. There's a fully insured medical component with 0.32, and that is a rate that we negotiate each year, but it's a smaller portion of the overall spend. Moving on to the next slide. So from a broad market context, we've kind of highlighted a number of drivers that we're seeing prevalent not only for the GIC, but for a number of our clients and plan sponsors as they navigate the uncertainty, not only in the short term, but the volatility and expected claims and utilization going forward. The first three boxes here represent the core components of medical and pharmacy trend. So, inflation is effectively a proxy for the unit costs that are based on reimbursements to providers and other suppliers. And, we'll talk about that in a slide in a moment. Member utilization is ticking up as well, with mix continuing to lean toward more expensive drugs and services. And Jeff will get into more detail on some of the clinical cost drivers that impacted our FY24 claims experience. Last year, when I navigated our presentation here, we introduced what we were seeing in the GLP-1 space. So these are drugs that are used for diabetes and anti-obesity clinical indications. Last year, we noted that it was a driver of the increase that we were seeing, and that continues to drive incremental spend that we're including in our projected rates. And lastly, in the blue square there is the impact of the Inflation Reduction Act of 2022, which indirectly impacts GIC spend in that it governs sort of a new enhanced benefit on the Part D individual market for prescription drug plans. And in 2025, that Part D plan is going to have a design that is more traditional with a deductible coinsurance and an out-of-pocket max. But as a result of the change in the design and the benefit enhancements on that market, we expect to see some higher subsidies for the EGWP program of the pharmacy component of the Medicare retiree plans. So that will help to offset some of the other drivers that we're seeing. It's noted here in the bottom, just from an overall market context, that the Federal Employee Benefits Plan recently announced in September of 2024 that the expected premium increase for 2025 is going to be 11.2%. So, they cited the increases are due to the impact of prices by providers and suppliers, increased utilization of certain drugs, and behavioral health spending. That 11.2% is an average across dozens of carriers and plans offered nationally. And in fact, it's going to be higher for member contributions because of the cap dynamics on a federal subsidy. So contributions will actually be going up about 13.5% as a result of those plan projections. In the case of the Federal Employee Benefits Plan, and just harkening back to the GLP-1 drugs, carriers are required to cover at least one GLP-1 drug for anti-obesity indications. And I'm sure that's driving some of the increase they're seeing with the 11.2%. From a more local market context, the merged market in Massachusetts is something that we comment on each year. Last year, there was actually a fairly favorable increase for 2024, despite high trends. This year, it looks like the increase is just under 8%, which is actually consistent with the average total trend assumption for medical and pharmacy. And according to the Connector's Director of Plan Management and Carrier Relations, the increases for nearby states are even worse. So, ranging from 7 to 18%. For Rhode Island, the range is about 8 to 12%, Maine over 9%, and Vermont at 18%. For Massachusetts in the merged market, GLP-1s are again one of the drivers cited, in addition to higher unit costs for inpatient, outpatient, hospital-based care and physician services. So, when we think about trend, there are, I guess, two things going on. We see adverse claims emerging in our claims base that we use for our projections, and then we look at the prospective trend estimates, which split, when we think about the unit cost versus utilization and service mix, about 2/3 of that trend assumption is due to unit costs negotiated with providers by the carriers, and the other third is typically due to utilization and service mix. On the next slide, we're going to dive into just inflation overall. And if you can move to the next slide. So, there's two aspects of inflation that correlate and drive the trend component for unit costs. One is general inflation. And so, we've seen that cool off a little bit. That's CPI-U. Then there's the incremental healthcare inflation that gets us to medical inflation overall. And what we've seen are that, medical care prices and overall health spending are outpacing growth in the rest of the economy. The CMS Office of the Actuary does an annual projection of multiple years of national health expenditures. And when you look at those as a percent of GDP, and that's including public spending, private spending, everything, the expectation is that we'll go from national health expenditures being about 17.7% of GDP in 2024 to 19.7% in 2032. So, about 20 cents of every GDP dollar in the economy is heading toward healthcare.
I'm sorry, if you're done with this slide, I don't want to interrupt you, but when you're done, just one comment.
Oh, sure. No, go ahead, Matt.
No, just to note the narrow bar graph in the middle here for public sector employers, and just to flag what this demonstrates is that in our current calendar year or current plan years for public sector employers, 2/3 are seeing trends in the current year that are over budget. So bear that in mind when we get to the CFO report that's coming a little bit later. This is unfortunately, a common experience in the healthcare market right now.
Thanks. And that's a good observation because, actually the survey data from the W2W Best Practices Survey goes back to early summer. So this was sort of fielding responses about how 2024 would look based on just, a few months of mature experience. I'm guessing if they were to go back and repopulate the survey based on what they know now about 2024, we would see even more plan sponsors with an expectation of being over budget.
Yeah. Hey,
Vince, can I ask a question about that?
Yeah, I see Anna's hand up and then Eileen. So Vince, if it's okay, can we field those questions, please?
Sure.
Go ahead, Anna.
Thanks, Valerie. I can't figure out how to raise my little emoji.
That's all right. I saw you. I saw you.
Zoom update. Okay, I appreciate it. I'm just curious, like, if you guys have looked at because like the GLP-1s, for example, are on the market equally in theory for everyone. Like, what's driving the public sector having this differential experience? Is it do you know?
That's a great question, and I anticipated that question, Anna, and Jeff and I were talking about this, and well, first of all, these are survey responses, so there's a different mix of public entities responding to the public sector survey compared to all industries. I believe we have about 450 or so respondents in total, and maybe 50 or 60 are in the public sector, so it's a good sample. I'm guessing that public sector leans toward having older populations with a higher prevalence of chronic disease. In the case of the GIC, that includes retirees who are on commercial plans, but they're not eligible for Medicare. We tend to also see richer benefits for public sector plans, which are common with unionized workforces, of course, and also more mandates and more covered mandates. Corollary of that is there are fewer high deductible health plans. So for the all industries view, they lean toward more options that put more skin in the game from a cost sharing perspective, and that has a dampening effect on overall utilization. And so maybe claims are less volatile. But the other thing that's not captured in the survey here is which ones are covering GLP-1s for anti-obesity indications and which aren't. And I think that plan sponsors, it's effectively a tale of two cities, depending on whether the drugs are covered. And so that could drive some of the additional differential in the survey responses.
Go ahead, Eileen. Thanks.
So first, Anna, Control-Shift-Y gives you the emojis. But I had a similar question. So it looks like there's not an insignificant portion, about 16% of all industries that come in below or significantly below budget. And I'm just wondering if there are common attributes or lessons learned, like how they are able to do that.
Yeah, I mean, for all the plan sponsors responding, cost is a concern, medical costs, containment, getting the most value for the healthcare dollar spent. I think everyone is very aware of their population's needs, the design, overall trend assumptions. I think what drives some of the emerging outcomes from a budget perspective are items like high cost claims. Some of the respondents will have more catastrophic claims than they would have expected. And that's likely driving their early view of how they were going to fare for 2024. But it won't be until the year is complete that they can go back and say, all right, what were the drivers? Was it high cost claims? Were there certain clinical outcomes that were favorable? What made those who performed better more efficient in the delivery of the healthcare dollar? So that's an analysis that is typically done in arrears. But some of it can't be explained, and it ends up being claims volatility. So there's just, adverse experience. And if you look at one plan sponsor's experience over time, there will be good years and there will be bad years. And typically, if we're setting a budget based on the best expectation of projected costs, it should be a flip of a coin as to whether you're over or under. Anyways, so this is definitely leaning toward over, however.
It occurs to me too, and I don't know how this plays out here, but public sector employers draft their budgets in a substantially different way and manage their budgets in a different way than private employers do. So for instance, for the GIC, we operate, our budgeted claims, we reconcile them to the budget from a July 1st to January 30th perspective, whereas I suspect that most private sectors and most purchasers on the private side would be able to accommodate run out where we can't do that. So there are, I wonder if some collection of the different ways in which that is managed and the timing that brings in here may have an impact as well. I'm speculating, but there are significant differences.
And just to add to Vince's point about volatility, 14% of the respondents had between 100 and 1,000 employees. So it's a pretty small number. So you would expect by randomness that there would be some that would show up under budget as long as the budgeting was done well.
Okay. So one other comment on inflation before we move on to the next slide. I looked at the data that's reported from the Bureau of Labor Statistics through November, and medical inflation is currently running at 3.7% compared to general inflation at 2.7%. So it's about a point higher. For a while during the pandemic, the relationship had flipped, but starting earlier in the summer, medical CPI began to outpace, the regular inflation. Now, this is representative of the cost of a basket of goods and services for healthcare. So it's really a proxy for that unit cost component. And the 3.7 is generally in line with what we're seeing as the unit cost component of our trend when we do our forecasting. Now that those stats are all kind of in the rearview mirror, and we're starting to see the impact of those higher negotiated unit prices with providers come through as the multi-year contracts are renewed. And there are other factors, cited in the bottom left there related to industry consolidation and, continued labor shortages as well as other factors. Okay,
Good, let's keep moving.
next slide.
All right, so what I want to sort of point out first of all is that medical costs really have been on the upswing over the last few years. So for over a decade, we had under 5% medical inflation, and it was still higher than general inflation, and we were complaining. But really, for the past couple of years, as you know, medical inflation rates have gotten dramatically higher. And as Vince pointed out, there's general inflation, there's high labor costs, there's provider consolidation, there's 3-year hospital system contracts that get renegotiated, and the old ones, had 3% rate increases, and the new ones actually are trying to make up for it, and many of them actually have the leverage to do that. And there's also, and I'll get to this a little bit more, but there is also medical innovation. So to some extent, medical care is better. People with cancer are living longer. There are, great new drugs to treat various things, and we end up paying for that. So very specifically, inpatient care costs have gone up. Now, again, for years, each year, what happened is the unit cost for inpatient care went up, but the utilization went down. But for the last couple of years, we're actually starting to see the utilization tick up as well as unit costs continue to go up. And this is even as some procedures like hip and knee replacements that used to take up a reasonable number of inpatient days are actually moving to the outpatient setting. Outpatient services costs have been going up for many years. That's often a lot of unit cost increase as well as utilization increase. Even so, for things like, for instance, hip and knee replacement surgeries that are moved to an ambulatory basis, they are cheaper there than they would be in hospitals. So even though the cost on outpatient goes up, that might not, that's not all bad. I'm going to go to GLP-1s at the end, but medical pharmacy costs continue to rise. So in 2024, there's a little bit of a relief because Humira, the anti-inflammatory used for inflammatory bowel disease and various types of arthritis and psoriasis and some other inflammatory diseases, that's finally available as a biosimilar. So that does lower cost. But overall, the cost of oncology drugs and the cost of anti-inflammatory drugs continues to rise and continues to rise rapidly. Substance use disorder costs are also going up to some extent. That's not terrible. I mean, we want more people to be getting care that they need. This is the first year where we're starting to see a decrease in opioid overdose deaths. So, more of this can be better. There's a special problem with out-of-plan services, and those represent those can represent a high cost, and we obviously would like care to be in plan. Then on to GLP-1 drugs, which is the next couple of slides as well. So these drugs have been used for about 20 years for diabetes, and there are two newer drugs, semaglutide and tirzepatide, that actually can lead to 15 to 25% weight loss in a large portion of the people that take them. And the challenge and the pharmaceutical companies have chosen to have higher prices for the obesity versions of these drugs than for the diabetes versions of the drugs, even though they're the identical medication. Over 40% of American adults meet eligibility requirements for these drugs based on being either obese or overweight with metabolic with metabolic complications of being overweight. And that's about 30% of all plan members, once you take out kids and things. And the costs after rebates and discounts are about $9,000 a year. So if even a modest portion of those who are eligible start on these medications, the impact on total cost is just huge. So move on to the next slide. So this is data from the GIC's population. Let me just orient you a little bit to this. So the yellow lines are GLP-1 drugs for diabetes. The purple are these drugs for weight loss. Pretty much all plans in the country cover these drugs for diabetes. I'll go over a little bit of why why that's the case. And what you can see is that in the active population, the amount of utilization of these drugs pretty much doubled over the course of a 2-year period, where the use of these drugs for obesity went up by 10 times. So this is the increase for both of these in the Medicare population, or in the retirees who are not eligible for the active plans, is actually much more modest. And so this obviously does represent a large cost challenge, and not really just for the GIC, really for any plan that's covering these drugs. So let me move on to the next slide. All right, so this is data from the 2024 Best Practices in Healthcare Survey, and so we did this in June and July. There are, as Vince pointed out, in the low 400s respondents, and representing about 6 million 6 million employees, or plan members, as opposed to plan subscribers. So, remember that probably represents 15 million or so people covered by these plans. What we found is that a little bit over half of the plans said that they covered these drugs, and that's you might have read about some other surveys that showed lower numbers. Our survey in 23 said only 38%. There's a KFF survey, used to be called Kaiser Family Foundation, that pegged coverage at 28%. They have many more very small employers in their survey. And the other issue is, I think that they did their survey back in January as opposed to ours in June and July. So I think that many more employers actually didn't realize they were covering these drugs for weight loss earlier. And that's also the reason why our number was somewhat lower in 2023. So in any event, a substantial portion of plan sponsors cover this, although any plan sponsor that covers these medications is finding the same kind of a steep slope that the GIC is seeing. So let me move on to the next slide, and this is just to point out that these are exceptionally clinically valuable drugs. So we increasingly understand that obesity is really a metabolic disease. It's not just a matter of, people should eat less and failure of willpower. And previous medications for obesity, as well as previous lifestyle interventions, generally just haven't been effective at driving sustained weight loss, whereas these drugs have and do, and they have been studied in clinical trials for well over 5 years, and the weight loss does seem to be sustainable. The drugs are covered, as I said, for diabetes essentially by all health plans, and amongst people with diabetes, they've been shown to decrease progression to dialysis or end-stage renal disease, decrease the number of major adverse cardiovascular events, lower the incidence of metabolic-associated steatohepatitis, which used to be called non-alcoholic fatty liver disease, which is much more common than we'd think. And also, they decrease all-cause mortality. So, frankly, if I were treating people with diabetes now, with type 2 diabetes, I think the best practice would be that almost all of them would be on these medications as long as they tolerated them. In terms of people with obesity, clearly they help people lose weight. That's not written down here as a well-proven benefit, but it unequivocally is. They also decrease progression to diabetes. There was a recent study of tirzepatide that showed a 90% increase, a 90% decrease in the number of people who progressed onto diabetes. they clearly are shown to help with sleep apnea as well. Eileen, if Commissioner McEnany, let me take your question, then I'll finish if that's okay. So
you can finish and I can ask afterwards, no problem.
Okay, well then, just to point out that, I mean, essentially obesity is associated with a lot of bad things, and it turns out that it's pretty likely that these drugs help with many of those bad things. And some of it might be that these drugs have some anti-inflammatory component because some of their impact, for instance, on their impact on arthritis pain in people with obesity that take them. Some of it is some of that impact happens before they actually reach maximum weight loss. So it looks like they're probably going to be helpful for some compulsive behaviors like addiction and gambling. They probably decrease obesity-related cancer. There's actually, I probably should move that that's been proven in people with diabetes because they've been used longer. So that's been studied already. There's one study that shows a decrease in diagnosis of new Alzheimer's disease. And although there's a black box warning on these drugs that they can increase suicidality, it turns out that in large large observational studies, actually there's substantially less suicidality and fewer actually suicide related events. So anyway, I mean, they are good drugs, and I shouldn't end without saying they're ridiculously expensive. It's really indefensible that the drugs cost so much, and the solution to this problem is really that we need to get lower prices for these drugs. And then Commissioner McEnany, thanks for being patient with me.
So, I mean, I guess I have a couple of questions. But one, you had mentioned that GLP-1 drugs have been available for about 20 years for diabetes, right? And that they have well-proven benefits. Yet we never see a reduction in healthcare cost in the trend. And we know that diabetes is pretty prevalent. So when you would think if it had all these benefits by now, we could quantify like what the medical cost savings are. And I don't know if you have that data, but I guess I'm a little skeptical because we hear about how all of these new medications and so forth prevent or work wonders. It never shows up in the medical cost trend. So like what gives, I guess?
So I think that this is a really important question. And let me sort of talk about the GLP-1s very specifically, which is that it's not inconsistent for them to both do all these great things and not save any money. And the issue is they do all these great things, but all the dollars that you can save from all these great things are less than the cost of the drugs. So what that means is these drugs might be cost effective, i.e. they buy some quantity of extra health, but they're not cost saving. Like they don't buy some extra quantity of health or health span or lifespan, whatever. And you also get a rebate in addition to better health. And Commissioner Snako can probably say this more articulately than me, but I mean, it turns out that within the medical system, there is childhood vaccinations and birth and contraception both save more money than they cost. But once you get beyond that, I mean, treating people for kidney failure with dialysis, treating people with cancer, these things don't save money. They just give people extra units of health or life. And so again, if these drugs were priced substantially less, then perhaps all the hospitalizations saved from cardiovascular disease and stuff would actually show up as real medical savings. But right now, the amount of money you have to spend on these drugs is more than we can save. Another example of this is that from 1980 to 2010, we had a dramatic decrease in cardiovascular disease in the country. Like, back when I trained, people had, people in their, men in their 40s, largely smokers, had, life-changing heart attacks all the time. I was treating in a coronary care unit, whereas now we rarely hear about that. Nonetheless, the total cost of medical care just kept on climbing dramatically, and that is to say that is that the cost of lowering bad outcomes was in many instances higher than what the benefit, what the economic benefit was. But again, most of the things, once they're in the healthcare system, most of the things we do don't save money, they just save lives.
And
Does
that's
that-
especially true in the United States, right? And less so the case based on how pricing is determined in other countries.
Sure. So that's an important point, Matt. So in the UK, these drugs are available for $100, for $100 versus versus $1,000 a month. That would make it easier to potentially save money.
Hey, Jane, I see you have your question. Can you take Jane's
It's
question?
related to what the commissioner just asked, and once again, I'm wading into demographic territory with my question, and also perhaps with my lack of knowledge. So I'd appreciate some response. I guess what I'm thinking about is if these drugs have been around for all these years, and we still are seeing an increase in the cost that you were talking about a minute ago. It makes me wonder if only people who are financially advantaged or have plans or are better protected than the large segment of people who might be lower economic, who will come down with diabetes. And, in other words, they're not being served and when it gets to a crisis point, they have to be served. And is that causing the costs to spiral upwards just because? I don't know if I'm explaining it right, but help me out on this.
No, I think Commissioner Edmonds has a really important point, which is, I mean, probably 3 years ago, there was a study of GLP-1s in New York City, and what they found is that on the Upper East Side, the use of GLP-1s was very high. In socioeconomically disadvantaged areas in Brooklyn, the use of GLP-1s was very low. On the other hand, the socioeconomically disadvantaged places actually had higher rates of obesity and higher rates of diabetes. So, this is I mean, I think that to the extent that the state has a diverse workforce, the state providing coverage of these actually is probably a helpful thing in terms of health equity. But there are still issues is that it might be that a primary care doctor in Wellesley is like very highly likely to be adept at prescribing these, and maybe a doctor in a community health center in Dorchester might be less likely to. But again, having the coverage at least makes it possible. But I think it's an important point. Something that I talk about in my academic work a bunch is that healthcare costing too much is actually a social justice issue. That when we make healthcare really expensive, it just becomes very hard for people who are poor.
I appreciate everything you said because I've often thought it is a social justice issue. When you think about people who are lower economic status and just can't, for whatever set of reasons, feel that they can take advantage, even if they have insurance of some kind, to be as fully protected as they could be. So I worry about those things, as I'm sure all of us do.
Yeah. Thanks, Jane.
Is this the last slide on GLP-1s
The good
before
news
we
is,
move to the
Matt,
rate? Yeah.
the good news is it is the last slide on GLP-1s.
Okay. I just want to say
Matt,
go ahead.
This is Tamara. I'm sorry. I don't know how to do the hand raise either. But I wanted to ask, since the GLP-1 drugs have been used for many, many years for diabetes, why is it that that there's so many individuals with diabetes that are obese, and it did not work against obesity prior? Did they change the formulation to work against obesity for some reason? If it's the same drug and the same chemical components, I'm just curious why it did not affect obesity before, but now it is affecting obesity.
Yeah, the earlier versions of GLP-1 drugs that became available 2 decades ago were only led to a modest amount of weight loss, but they improved hemoglobin A1C and they improved diabetes control a lot. The more recently approved drugs, which are on patent for much longer and which are much more expensive, both improve diabetes, improve diabetes control, improve diabetes outcome, but also are much more effective at helping people lose weight. So, and by the way, I mean this. It's just a single point. So maybe we'll have to wait a couple years to see. But it does look like obesity rates have plateaued or even decreased a little bit in the United States over the last year. But again, the earlier drugs that are now increasingly becoming available generically were only they led to under 5% weight loss, whereas these drugs, 15 to 25% weight loss. So they're much more effective for obesity.
And does this work for children too?
Um, they are approved, and Devin, our pharmacist, is also on the line. I think they're approved for ages 12 and up.
12 and above, yeah.
Yeah.
So Jeff, one other thing I wanted to add about your prior comment about the older drugs versus the newer GLPs. The GLPs that came out 2 decades ago, they were injected on a daily basis. So the alternative was tablets, injection daily. Most people said, well, we'll take the tablets and not the injection.
Okay.
The newer ones now are more potent and are taken once a week. So there's more acceptance in the general community about using these products. So we're definitely seeing a much more uptake of these drugs for diabetes now.
Okay, thank you.
See, Eileen has another question.
Sorry, but
that's all right.
So I'm thinking about future medical trend, and a couple of the statistics you said are pretty alarming. That 40% of adults would qualify, for the obesity drug version of the drug. And you also mentioned that increasingly obesity is seen as a metabolic, like chronic condition. I guess what I'm wondering, because to me, if both of those are true, we have a serious population and public health problem that should probably be addressed in a different way. But I guess my question is, are you suggesting, or is the literature suggesting people are born with this metabolic condition, or it develops over time? I guess ultimately I'm wondering, is obesity, does it start off as kind of environmental or like choices and then turns into a metabolic disease, or are you born like that?
I think the answer is both. That there is some evidence that even in utero exposure to hormonal exposure and in utero exposure to the milieu of a mom who might herself be obese actually plays some role. About 75% of obesity can be accurately predicted by parental obesity. Some of that might be environmental too, but I think that from a public health perspective, the best thing is let's be sure that kids have access to nutritious food and a whole lot less processed food, and let's not let kids get obese. And that's gonna mean that because once people are obese, losing weight with things other than these very potent drugs is very, very difficult. And not just very difficult, but just a relatively small portion of people who legitimately try are successful. So yeah, I mean the right thing is let's sort of start at the beginning and make it easier for children to not get obese in the first place. But for many children, they are genetically predisposed to this, and they can have wonderful, amazing willpower and exercise ridiculous amounts, and they still will have obesity. So I agree with you. It's a big public health challenge. And again, the drugs are a very good answer. I mean, we want to both improve the public health situation, but also be sure that individual people don't have heart attacks and have kidney failure and need dialysis. go blind from their diabetes. We want to do both of those things. The drugs are very helpful for that, but we do need to keep on thinking about all the public health things to do to make it easier for people to, exercise right and eat more nutritious food.
Thanks. I mean, my concern is with with a pill, will discourage some of that healthy behavior, right? Because it's just easier to take the injection, and that's the concern.
Yeah, yeah. But again, I mean, years and years of people doing lifestyle interventions have not shown a lot of efficacy of it. So, if we're going to discourage people from doing things that weren't very, very helpful in the first place, there's not as much harm in that. But I understand your point.
Yeah. No, good discussion.
So before we wrap this, this has been a really helpful discussion. So thank you for all the questions, and thank you, Jeff, for the contributions to it. It's quite clear, I suspect, to all commissioners that this is a real dilemma. I had a phone call with one of the manufacturers of one of these drugs earlier this week, which was interesting. And what I said to them, and I'll say to you, is that I think in a different circumstance, we would all collectively celebrate without any reservation the advances that these drugs represent. The pricing and the potential of the ceiling of utilization, which we are nowhere near at this point, and we're already facing very difficult decisions, right, on this and others. So when we spend the amount of money that we spend on GLP-1s, it's money that we can't spend with limited budgets on a variety of other really important things in the healthcare, in sort of specifically speaking, like plan design and coverage, but also other initiatives. So we talk a good deal about expanding access to behavioral health. And substance use disorder. Those are all urgent needs of areas, and they lead to, and they should lead to, in some respects, higher spending on those things. There are steps that we can take in the health equity space that come with invested dollars that become a lot harder to make progress on when one drug class for one diagnosis consumes such an enormous part of our budget. So I expressed it with a little more urgency and spice with that manufacturer of the drug, but it presents real challenges, and I just remind everybody of the trade-offs that these sorts of things force us to make, none of which are good. I see Anna has a question.
Yeah, I was just gonna add that I mean I was just gonna second what this was a great presentation and what Jeff was saying about the these aren't cost savings, they are cost effective, which means that more use of them leads to better outcomes for people or outcomes at a cost we think is worth it. But we just can't it's just kind of like what Matt was saying, you can't have it all, right? So there are these trade-offs. We want to really make sure we're spending the money where the health returns are worth it and something that we value, and then not spending it or making different choices if the value isn't as good. That's not easy. It's not going to be easy, but it's sort of the way forward, I think, and really understanding where these new therapies, which really are effective, can bring the greatest value is where we want to invest in them. So hopefully we can learn more about that going forward. I also just wanted to echo what the conversation on equity, and I think there are concerns about access to more expensive therapies, and you can think about different ways to try to increase access. employers have benefit design to work with, and other stakeholders can do other things. So just saying that, we can talk more about that in the future.
Yeah, thanks, Anna. I don't see any more questions. We may be able to move from this topic. Jeff?
Thank you, commissioners. Very good discussion.
And I can hit on the last slide before we move on to Jim's section. So, of course, the GLP-1 driver is part of why we're seeing an initial expected increase of around 10.5% for FY26. This is our status quo estimate, so it's based on the current plan designs. No plan design changes are taken into account yet. So if you go back to last year's materials, I think we started around 9.5%, but then we finished our pricing process with an FY25 increase of 8.5%. And so, this is an average across Medicare and non-Medicare. So there will be plans that are below and plans that are above this average increase. And of course, we're not done with our work yet as we continue to work with the carriers on our prospective trend assumptions, reforecast GLP-1 spend for FY26 based on our emerging data. And we'll look at that as recently as November. And then also figure in any potential changes on pharmacy rebates or EGWP subsidies, which help to offset some of these increases. So other things that are driving the initial estimate of 10.5%, for the GIC, claims experience for FY24 came in worse than expected when we projected it a year prior. So medical claims emerged about 2 points unfavorable for non-Medicare and 4 points unfavorable for Medicare, which was a bit of a surprise on the med sup plans. But we were seeing trends in sort of Part B coinsurance charges under the med sup plans driven by medical specialty and surgeries, but also the fact that a lot of the claims in the med sup plans are actually what Medicare doesn't pay, and a lot of the traditional Medicare cost sharing provisions are impacted by inflation. So the uptick in inflation itself, which is starting to cool off, drove some of the higher trends we were seeing on the med sup plans. For pharmacy, claims actually emerged a little bit better than expectations for non-Medicare, but 5 points unfavorable for Medicare. Then, we went back and asked the carriers for their trend assumptions for medical trend. The non-Medicare average trend increased from about 5.5% last year to 6.1% this year. But there's a range with carriers forecasting between 4.5% up to 9% for medical trend. On the Medicare side, the average trend increased from 2.7% last year to 5.2% this year. So a big loss on the trend assumptions that were provided by our carrier partners. For pharmacy, of course, where the GLP-1 spend is, we saw double-digit expectations of trend increases for utilization and unit cost, around 12% for Medicare and 14% for non-Medicare. So the good news is the impact of the adverse claims experience was mitigated, like I said, by higher EGWP subsidies and rebates. And that is cooked into our expectations of the full cost premiums on a prospective basis, and is definitely the good news. So any questions on where we stand now for the status quo preliminary FY26 increase?
I had a question. Toby showed us. I don't know who to direct this to it. Did somebody put a dollar number on the 10.5% of the budget impact? Roughly, just a rough dollar number, how many billions? I hope it stays billions.
Yeah, I can say that it's roughly $3.9 billion with a B before contribution. So that's just looking at projected claims for medical pharmacy admin fees, all that, but that doesn't tie in any way to budget expectations due to other factors, primarily the contributions and state share. And
right, but the 3.9 billion is a total expenditure.
As of now,
yeah.
it's a little bit under, but And
Okay,
it's
what's the increase? What's the delta roughly? I know this is rough ballpark numbers.
that I don't have.
To me, that brings it home versus percentages. I know you gotta go with percentages.
Mhm.
Okay, thank you.
Yeah, and I guess I'll ask Matt and team to comment on, prepping the administration, what do we see in terms of ability for being able to provide us what's needed for these projections? Where's that thinking?
Yeah,
Yeah, I
and
can say
going
that.
back to the question,
ahead.
if I may for a second, Commissioner Choate, it looks like our budget is about a $282 million increase request, which is probably ballpark to where we are with what Vince just
Okay.
announced.
Thanks, Jim.
Go ahead, Matt.
Yeah, thank you for that, Jim. So as we are this year, as we are every year, in very close touch with our colleagues and the governor's A&F budget team about all of our projections. We need to do that to inform the crafting of the FY26 budget. So there's a great deal of awareness of the challenges that we face here. Of course, we have an A&F commissioner, an A&F designee here on the commission who's been following along with this discussion. So, those discussions are ongoing.
All right, good. I don't see any other questions, so let's keep moving. Thank you, WTW, for the information. Appreciate that.
And so at this point, turn it over to Jim Russ to bring us home with the CFO report.
Hello, Jim. You're on mute, but we're excited that you have plenty of time
Thanks.
to talk to us today. We haven't run out of agenda time for you.
Good. Good. Yeah, we have a little bit more to talk about than usual today on the CFO report. But if you have any trouble hearing me, let me know. My government issue computer's microphone gave out this morning, but I think I found a headset that's working. So this is a good follow-up to what Vince and the WTW team just presented to us. We're going to give the first update on FY25. And we have 4 months in the books now, and all the same factors that Vince and Jeff and team talked about that are affecting FY26's projections are, of course, embedded here in FY25, and we're experiencing them right now. Real quick, before we leave FY26, I think just to follow up a little bit on what Matt said about the process, we submit budgets and budget updates to administration and finance all through the fall to keep them in the loop as to where we are on spending for this year and where we're projecting spending next year. So as Matt said, there's a free exchange of data and budget updates going on there, so they're aware where we're at, and we're working with them closely. Okay, so on to these slides. This slide you may recall from prior years is our state share payments to all our vendors for healthcare and other benefits, and is mostly informational, but we'd like to provide this to you. And the next slide is the enrollee share of the same expenses, and then they would have the same pattern as the state share expenses. Next slide, please. Okay, so getting into the projections, as you can see here, the blue line is where we projected costs to be for this year through November. As the shape will tell you, we have the shape pretty well nailed down, but the red line is what we actually spent. And unfortunately, as you can see, the red line is above the blue line all through the first 4 months. So spending has been above projections every month of the year so far. Next slide, please. And this is the same data, but it gives you a view of where the spending we expect it to go for the next several months of the year for the second half of FY25, and the shape of the spend for the GIC. So informational. Next slide, please. And here is a slide that is, as you may recall from prior years, is a cumulative budget as we go through the year. So normally, since our budget is quite large and our variance is usually quite low, the the two lines lie on top of each other, right? But this year, given our budget and spending situation, there's daylight between those two lines, and we don't particularly want to see daylight between them, but that's the situation we're in now for FY25. Next slide, please. Okay, so here are the numbers. Through November, we're $100 million over budget, so that's about 9% of the total spent to date. I think for my time here, this is the largest variance that we've had, particularly at this time of year. The drivers are the same. There's a limited amount, as Vince mentioned earlier, of things we can see as we're in it. As for the drivers it's better to look at the end of the year when things like high cost claims and other drivers can be dealt with. But we know what's driving it to some extent, because we can see the month-to-month spend on certain things. The GLP-1s are definitely a large part of this, but there's also an increase in spending from all the plans on healthcare costs, mostly around pricing more than utilization. So we can see that, and we have reporting from the plans on that. Some years we have a variance, maybe not quite this large, but we know that it's going to resolve itself, because maybe we had a rebate payment come in early or late, and this can cause the shape to be off. Unfortunately, it's not the case this year. We expect that this trend will hold, and that this variance will actually grow over time, and we're working with our partners, our vendor partners in W2W, to try to get our hands around where that might end up. But so that's where we are this year. As we go through the year, we'll keep you apprised. We're working with the folks at Administration of Finance, and they're working with us to help resolve this and to work with our projections in order to make sure we get this funded. So we're confident we'll resolve this in some way. And with that, I will take any questions you have.
I don't see any questions.
I have one, Jim, Toby Chodo.
Sure.
You mean resolve it? You mean get an increased budget?
Yeah, there could be, I don't want to presuppose, but there'll be another funding source. It could be supplemental to our budget, or maybe there's another source of funding that, we'll work with the Commonwealth, whatever way they think is appropriate to fill the gap and to get our hands around what the gap actually will be. As you know, we pay claims every week. So, we have to manage cash flow here as well. We can't run out at any particular time. The plan, as a self-insured entity, the plans count on us to reimburse them weekly. And there's a large variance in that, but they're aware of all that and what the constraints are for us. So we'll work with them on that. But it could be something like a supplemental budget.
The range of options is find more money.
Yes, that's right. Yeah, and from our perspective, we can work with them on what the best way for the Commonwealth is to find that, to deal with that. But as long as it ends up in our budget, we're fine with that.
Thank you.
So we'll be back monthly to let you know where we are as we go through this.
Yeah, please keep us posted and be prepared, to provide us the details on, what the resolution for this shortfall is. It's been a while since we've had one like this.
Yes, it has.
All right, I don't see any other questions, so we can keep moving.
That really brings us to the end of today's agenda, ahead of schedule, but we really wanted to make sure that we left sufficient time to walk through the financial challenges that we face as we head into the next year. So I see Eileen has a question.
Yeah.
Yes, thank you. So I'm just wondering if the 10.5% aggregate increase that we talked about, is that based on the actual data? So we accounting for the extra spend of the 100 million, or how do you calculate that, I guess?
Yeah, I can take that. So what we do is we forecast the total spend, for example, for GLP-1 drugs for FY26. And so, part of that work is to also look at what was in what we expect to pay in FY25 that wasn't baked into the rates when we set them a year before. So what we're seeing now that's driving some of that overage in the FY25 budget is captured in the initial estimate of 10.5% for FY26.
Thank you.
Hi, Rebecca, I see you have your hand up. Go ahead.
Yes, I just wanted to thank the consultants and the GIC team for all the hard work. The kinds of issues financially and with respect to benefits are being seen across the market. And I personally greatly appreciate the kind of data that I receive in these meetings. It's very useful to me in my role at the Division of Insurance to see the kinds of trends that the GIC faces match and often are typically are exceeded by other trends that I see in the commercial market. But the level of data that this group receives, I think, we should really be appreciative. It's something that I certainly am appreciative of.
Oh, well, that's great, Rebecca. I appreciate that too. I feel the same way about WTW. I think we have a terrific team working on this. And, I think all of you who know me know I'm a data nerd. So I echo that, Rebecca, and I'm thrilled that you spoke up. So thank you. I see Joe has his hand up. Hi, Joe.
Good morning. Matt, could you mention something about the recent issue with WellPoint and Bay State and how these issues may become more common?
Yeah, I'm happy to. Thank you for that question. And I think we've touched on it, but only briefly in passing over the last couple of meetings. So as I've described, and I think we talked generally at great length in our November meeting, that the climate in the marketplace right now on rate negotiations between providers and carriers is extremely challenging. And it's more challenging than at any time that I've been in healthcare for 15 years. And, we stay in pretty close touch with our carriers to keep tabs on that and to understand what's happening in the market. And we routinely now see rate demands from provider systems that are several multiples of CPI, several multiples of the healthcare cost growth benchmark, routinely in the double digits. I don't know if I've shared this one in prior commission meetings, but we did hear of one provider who demanded essentially a 50% rate increase over 3 years in a contract negotiation and expressed an unwillingness to budge from that right from the beginning of the negotiation. So, this is where the challenge of maintaining wide access and sustainable unit prices, it's where that really all comes together. So we, in those conversations with our carriers, we strongly direct them to negotiate very hard with those providers. We have performance guarantees in place with each of our carriers where they have a portion of their administrative fee at risk if they can't keep our trend closer to and aligned with the benchmark. And so we're doing everything that we can. Our carriers, I believe, are doing everything that they can. Those negotiations can sometimes get very contentious and can become public. And we understand that those present concerns for our members, rightly so, where they may, they'll read in the paper about a potential contract termination with a provider that they access on a daily basis, or not a daily basis, but a regular basis. They receive notices occasionally. In the case of WellPoint and Bay State, they received a notice from WellPoint that they may lose access to Bay State as an in-network provider. And so that can be troubling and disturbing to people. So so we're always trying to find that right balance, right, of making sure that our carriers maintain access to needed services, but it has to be at a rate that we can sustain at the GIC. So it hasn't just been the WellPoint Unicare dispute, which thankfully resolved with a sustainable contract. We don't get involved. Let me just make clear, we don't get involved in these negotiations. We are not a party to these negotiations. We observe them and we talk regularly with our carriers about them. But we read in the paper about others. Point 32 has not yet, from my understanding, reached agreement with Tenet Healthcare. 3 hospitals involved there. Outside of the GIC for Connect to Business, Point 32 is having challenges with UMass Memorial in Worcester and Children's Hospital. This, as long as providers are demanding the rate increases that they're demanding, this is going to continue to be an issue. So I would say, from my standpoint, I acknowledge, and I think we should all acknowledge, that it's a particularly difficult time for some, or maybe many, provider systems to maintain a sustainable balance sheet. At the same time, there are limits to what we're able to tolerate in terms of provider pricing, and I say that as the executive director of the GIC, but I say that as a reflection of what the Commonwealth has said when they created the HPC and passed Chapter 224 back in 2012. The principle of 224 was we can't have healthcare spending continue to outpace growth in the state's economy, because when you do that, it gobbles up an increasing share of state resources and our members' individual resources, their paychecks, to meet the objectives that we all share. So it's a long-winded answer, Joe. It's one of the, let's say, that and the GLP-1 drugs for weight loss are the 2 things that keep me up at night. I hope that answers your question.
Yes, thank you, Matt.
Yeah,
Thanks, Joe.
That's good. I see Bobby has her hand up. Go ahead, Bobby.
Thank you. I just also am curious. I don't know to whom this should be addressed, but the lack of primary care providers, right, and the sort of trend of whoever is left moving into boutique services, and what that impact will be, because the waits for just to see a primary care provider are longer and longer because there are fewer of them. And I wonder if I don't know if Jeff, if you have seen any impact on in our plans, right, and what that trend might be, and how that would impact cost, I guess.
Before Jeff chimes in, he may or may not still be on our speaker panel here, but if he is, welcome his insight here. I will say, though, that linking back to my answer to Joe's question, we have made it clear to our providers, to our carriers, that we feel it's important to strengthen primary care, right? And I would say, I don't think there's anybody who would argue that more of the healthcare dollar needs to be spent on primary care and preventative care for the wellness of our members and a more sustainable cost trend. I will say that in our conversations with carriers, so they're trying to move that objective forward in their rate negotiations, right? We'll agree to this rate if implicit in this rate is an increasing share of that dollar that goes to primary care. we see the opposite frequently from hospital systems who want to plow more money into sick care rather than healthcare. So I guess I go back again to the trade-offs that we need to make in all of our discussions. And unless we do things differently and we move the system in a different direction, I say we, I'm talking about the Commonwealth, we're going to continue to see a declining share of the healthcare dollar going to primary care, not an increasing share. That's what I worry about. I don't know if Jeff is still here and wants to chime into that.
Yeah, no, Matt, I agree with you fully. And to Vice Chair Kaplan's point, I mean, we have a really big challenge in primary care. I mean, pediatrics, family medicine, and general internal medicine residency slots haven't filled for the past bunch of years. And so, we have a structural problem that we will have, we will have 35,000 FTE primary care doctor shortage by 2032. And frankly, it's even worse in rural areas than it is in urban areas. So I think it's a real problem. I think that the kind of good work that the GIC is doing and that the state is doing to try to be sure that more dollars go to primary care is an important piece of the solution. But I also think that we're probably going to see, more attempts to do more of primary care with virtual care and other things, just because there aren't going to be enough bodies to provide this. And and as you said, some of the people that are in primary care are there's a Commonwealth Fund study that just came out that suggests that 45% of primary care doctors are feeling burned out, and a third of those are making plans to leave practice. So yeah, it's a huge crisis, and it matters to all of us because all of us want to have primary care doctors that know us, so that when we have medical needs, they can help us navigate this sort of incredibly effective but very tough to figure out system we have.
Yeah, and I would just add one item to that too, not to get too far down a rabbit hole here, but the hope and vision for payment reform, moving away from fee-for-service payments to more global type payments, was really designed to move in that direction, where we can have a payment structure that's given to a provider system that incentivizes them to keep the member well, and they have the ability, the financial flexibility to invest more in primary care, and ultimately they would do better on a flat payment, a flat global payment, if they're able to keep people well and out of the hospital, keeps costs down. They do better financially, as opposed to fee for service, where you're just getting paid for each service you provide, and all that means is you're providing more of the service and typically more of the high margin and high cost services. So so that is an unfulfilled vision in healthcare. We've been making a number of efforts. The GIC had, before I got here under Dolores Mitchell, had a payment reform initiative, the name of which is escaping me, but that was really trying to drive carriers to these alternative payment methodologies. It can really only produce the kind of change in behavior and system change if it really, at the end of the day, changes the behavior of healthcare systems. Are they able to restructure care? Are they able to support not only primary care providers, but nurse practitioners, physicians assistants, encourage team-based delivery of care, instead of it always being with a doctor or a specialist? It's a really big challenge. I'm grateful that a lot of smart people are thinking about it, and I think we have an opportunity to play our part as as policymakers and system leaders continue to lean in that direction.
Thank you for that. Thanks.
You're welcome. Yep.
Thanks. Thank you, Jeff, also.
Right.
Yeah. Well, I don't see any other questions. Any additional business items folks want to bring up? So one piece of other business that a couple of the commissioners asked me to elevate and provide reminder is how excited and pleased they were with last month's Health Policy Commission meeting and the desire to have a follow-up, potentially to use some of the information that was presented by the HPC for strategies, action plans, and execution to be able to show measurable, demonstrated ability to make a change, especially with the clout that the GIC has. So please, staff members, take note. Can we get another meeting with HPC in the first half of the new year? That is the request by many of the commissioners here. So I don't know if anyone wants to piggyback on that, but it is a piece of business, not just for discussion and debate, but also for figuring out some actionability and demonstration that our clout can make a difference in an area that we all care about or can agree to care about. Go ahead, Eileen.
Sure. I mean, I'm happy to echo and underscore what you're saying. I think the HPC has done work for 12 years now, and the cost drivers are pretty consistent. And I actually think it's the responsibility of GIC as the largest probably purchaser in the market to try to lead change, right? I mean, I went to the HPC's cost trend hearing, and there was really, in my estimation, a collective cry for systemic change, right? It's not working for anyone. And I think we have both the challenge and the opportunity to try to lead and affect some of that change. And I think we should give it our best effort.
Yeah, thanks, Eileen. And so I think Eileen and I speak for many on the commission who want to see action and a plan to get to that outcome where we show, I mean, we can't change everything, but where we focus our efforts, we show that we can deliver results. So, let's see what we can do in the first half of the year. I know we're going to be dealing with the rate increases, but I also think we have a very talented staff that can also find a way to be focused in an area that this, group of commissioners wants to see. So thank you. So at this point, I can give you 11 minutes back in your agenda if I have a motion to adjourn.
Motion to adjourn.
So Toby, do I have a second on that?
Second.
Second we have. So all in favor, say aye.
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 Any naysayers? I didn't think so. So everyone, I want to wish you a wonderful holiday season, prosperous new year, good health. Very much appreciate all of you. And I hope I see you in person in 2025. So bye, everyone.
Thank you all.
Thank you.